Welcome to A Deadly Silence, and I'm your host, Larry Curtis, and it is the goal of all of us affiliated with this program to bring to you current and updated information around the opiate and alcohol epidemic that has been surrounding the South Shore communities. With us today is Senator John Keenan. Senator Keenan is the chair of the Joint Committee of Mental Health and Substance Abuse. Senator Keenan, welcome to our show.
Good evening. Thank
Good to have you back again.
Great to be back.
I want to start off briefly by just kind of, highlighting a little bit from the November 2009 Oxycontin and Heroin Commission release, the report that came out. It cited a few issues that Massachusetts has one of the highest rates of opiate addiction in the nation. And between 2002 and 2007, there were 3,265 deaths related to opiate abuse here in the Commonwealth. There was an excess of 23,000 hospitalizations in 2006, and there was an estimated cost of $4.5 billion associated with this epidemic, comprising of healthcare, courts, incarceration, jail, and social services attempting to support the addicts. Has there been any improvement since this commission's report, Senator?
I'd like to think there has been, but I'm not so sure, really. I think perhaps the greatest area of improvement is that there's more awareness of the problem. Back in 2005, 2006, 2007, the years leading up to that report, there didn't seem to be as much awareness of the problem as there is now. And I think once people become aware of it, then you are better able to tackle the problem. And people are more interested in being involved, more interested in making sure that we have the resources we need to fight the epidemic.
And are those resources, have they continued to be available, given the state of the economy, given the Commonwealth's, limited resources, obviously?
Well, the governor, the House, and the Senate have all made a commitment to funding it as best as possible despite the economic times. And we have to spend a certain amount in order to get federal funds. So that's one thing that helps us in our efforts to make sure that we have as much funding as possible. But clearly, as you get out and about and you see the families that are suffering from this, the individuals that are suffering, there's more that we can do. There's more, I think, that we have to do, and it is difficult to find the resources to meet those needs. Right.
And I would agree with you that when you go back 5, 6, 7 years ago, that this was a hidden epidemic that nobody wanted to recognize, and that, we've come a long way since 2005, 6, 7 to make the awareness that this is a significant issue that we need to address and move forward on.
Yeah, we have. I think the stigma is disappearing, fortunately. Again, it's hitting all families, so there's really no place to hide anymore.
Right. Mm-hmm.
And so it's coming out in the open, and that's a great step.
Yeah. Recently, back in July of 2010, the Commonwealth passed an act relative to prescription drug diversion, abuse, and addiction. Can we talk about some of the changes of what this act meant to be? One of the ones that stood out was they were going to codify and expand prescription monitoring programs from just Schedule 2 prescriptions to Schedule 2 through 5 prescriptions. What does codified mean, and what is the difference between a 2 or a 2 through 5?
The drugs are scheduled according to a whole bunch of different things, but one of the things that they're scheduled to is their susceptibility to be abused, or the potential for abuse. So you have the higher that they are on the schedule, the more likely they are to be abused, particularly when it comes to painkillers, and then they make their way down. There's Schedule 2 drugs that include most of the opiates, and then there's Schedule 3 that include drugs such as Vicodin. And one of the aspects of the legislation that we've recently passed in the Senate is to reschedule Vicodin. And once they're on different schedules, there are different prescribing protocols that are in place relative to each of the drugs.
So the lower the lower the number, the less potency, and the higher the opposite.
You're correct.
Okay, so the higher the number, the less potency, but the lower the number, the more potency. And we're finding that while these have been prescription drugs, basically we're finding that more and more of these drugs are now getting out into the hands of the addicts through many different means.
They're being diverted, whether they're in somebody's home and somebody comes into the house and takes them, or whether somebody's giving them to somebody saying, I have a bad shoulder, and somebody say, try one of these. They're being prescribed by way of individuals who are doctor shopping, meaning they'll go to several different doctors, get prescriptions, and fill those prescriptions for their own use or to sell them. So there's a whole variety of ways that the drugs are making their way from the pharmacies to families, to individuals, and then ultimately to the streets.
Another area that was highlighted in the act was improved access to substance abuse treatment facilities. Can you elaborate on that from the standpoint of the addict or maybe even the family who may be having an addict dealing with it?
Sure. One of the things that we commonly hear is somebody will be in a position where they've reached the point where they want to get treatment. And oftentimes there's been a lot of bureaucracy involved in getting somebody to treatment. It may involve insurance companies, it may involve Mass Health if they're on Mass Health. There's a lot of hoops that have to be jumped through in order to get access to the type of recovery that they need. For instance, they may go to a detox, and then there's always a battle between the detox center and the insurer. How many days is appropriate? Is it 3 days, is it 4 days, or is it 5 days? Once that detox is done, then the next battle begins as to what's the appropriate next step. And the insurance companies and the providers, for instance, the detox center will have a discussion about whether a step-down program is necessary or the best next step. And that might be a 5 to 7 day program, and then it becomes an issue of whether somebody should then go to an inpatient or a residential treatment program. One of the things that's coming up now is that insurance companies won't always pay for the detox program. They are frequently now sending people home to detox on their own with Suboxone. And I don't know if that's the most effective way. I find it difficult to accept that being the most effective detox, but that's what insurance companies are doing now. And if that doesn't work, then they may consider an inpatient detox.
And there's been issues out there that I hear that, you know, if somebody is in detox, they have an insurance that may have covered the 3 or 4 day period of time, that if in event the addict would relapse again, they won't cover a second detox for 90, 120 days or something of that nature.
Right. There's a lot of that going on, and we're trying to put in people's minds the idea that there's supposed to be parity. There's supposed to be parity between medical health and mental health and substance abuse treatment. And there isn't in the Commonwealth, and there isn't across the country. There is a Federal Parity Act. People who have substance abuse problems and mental health problems are supposed to receive the same treatment, basically, or have the same access to treatment as those with medical problems. But we find that it doesn't. If somebody goes to an emergency room with a substance abuse overdose situation and maybe requires a detox and then a program, they may wait in the emergency room for treatment, whereas somebody goes in with a heart attack or a case of diabetic shock, they get immediate treatment and they're transferred to the appropriate bed. It doesn't happen on the mental health side, it doesn't happen on the substance abuse side as it should.
Yeah. So we're still fighting that stigma that an addict basically has caused this themselves, where a basic regular illness may have been, even though it might have been cancer or anything of that nature, it will be looked at seriously and be treated more frequently than the addict who perceptually can cure themselves to some degree. That's tough. That's tough out there. Another area in the act was mandated practitioner education and pain management. Let's talk about that, because I think that's becoming an issue in relationship to people who are, in essence, suffering from chronic pain.
Right. Going to the piece of legislation that we just passed in the Senate, we've taken the education piece to the next stage, and the registration in the prescription monitoring program, enrollment in the program to the next stage. And one of the concerns that we heard as we were preparing the legislation was from people who suffer with chronic pain. Are you going to make it too difficult for me to get the medications that I need? And just about 3 weeks ago, after the legislation passed through the Senate, I ran into somebody who had bone cancer. And he said, if I didn't have the Oxycontin, I would not have gotten through the bone cancer treatment that I received. And he said, I'm just afraid that your legislation that just passed the Senate is going to impact that. And I explained to him that in his case, for instance, once he was diagnosed and he went to his oncologist and they discussed treatment options, then if Oxycontin or some sort of a painkiller was going to be part of the treatment program, the only requirement on that oncologist relative to that treatment was the first time the oncologist prescribed a painkiller, the oncologist would have to run a prescription monitoring program screen. And what that is when you get a prescription filled at a pharmacy, for the last several years that information has been going to the state. So the information is there. That oncologist, the first time prescribing a prescription painkiller to that cancer patient, would run a prescription monitoring screen. If everything checked out fine, would write that prescription. And from that point on, they would establish a physician-patient relationship, and they would determine between the two how to best handle pain. And what we're trying to do with the legislation wouldn't impact that. So we're very sensitive that people have chronic pain, and we're trying to find that balance. And I think we've succeeded.
Okay. There has been some fear that this act may have kind of restricted access to the chronic pain patient in relationship to the supply of medication that might be available to them. You see pharmacy prescription programs now basically asking you to do mail order and 3-month supply. Is there going to be any effect on that type of access to the pain medication that the chronic person may have?
No, really, if somebody has legitimate chronic pain, then this legislation really shouldn't impact them. The legislation is designed to prevent the diversion of pills from legitimate chronic pain users to people who are using them recreationally, and then because they're dependent or become addicted. It's designed to better inform the public of the dangers of prescription painkillers. It's designed to limit the ability of individuals who do not have legitimate pain, but who are out doctor shopping because they're dependent or addicted, to limit their ability to get pain medications. For those with legitimate pain who demonstrate that legitimate pain to their physicians, there really shouldn't be any interference with the treatment of that pain.
Okay. Another area was when we talked earlier about the access to treatment facilities. There was going to be a study on sober houses to be undertaken. Can you enlighten us on that?
Sure. We hear on an increasing basis that people have concerns about the way sober houses are being operated. As with anything, it seems there are good operators and there are poor operators. There are operators who are in it for all the right reasons, and there are operators who are running sober homes for financial gain, perhaps. And we've had people from the sober home community approach us and ask us to put together regulations because they want to weed out those that are giving sober homes a bad name. We have recovery homes in the Commonwealth of Massachusetts that are regulated, that are very well run, that are inspected, they're subject to review, they're subject to audit. They offer a great program to people who are suffering with addiction. Sober homes are less structured. Many experts will say there is a place for them within the continuum of care, recovery care, but they have to be run properly. And so those who run the homes are looking for some regulations, and we're looking at that now as to how we can go about that.
And is the kind of the reimbursement or the support necessary for a resident, I guess, with this case, is that taxpayer funded, private insurance? How is that more or less looked at?
It's private insurance. It is through Mass Health. People order to them, self-pay through the courts sometimes.
Okay.
There's a combination of things, and it really depends on the structure of the sober home. Some of them are nothing more than a collection of rooms where everybody in the home agrees that they will remain sober. Some of them are much more involved. They may have drug testing. They may have 12-step programs on site for when people come back from work, for instance. So it really depends on the type of facility and the programs that are being offered as to whether it is...
And those reputable homes have really come forward and they say, hey, we're really trying to do the right thing, but we recognize there are some bad operators out there, and we need to, champion our cause for the care of the addict moving
Correct.
forward.
Yeah.
That's terrific. A key area, because this addiction is hitting on the young adults in even grade school up through high school, was a curriculum based around school education. What's been the most difficult aspect in trying to develop a curriculum for the education of the young children out there?
I think it's been what form it'll take. Will it take the form of something that's offered through the health programs that are provided in schools? Is it something that will be a standalone curriculum? Will it be a full semester curriculum? So there's that kind of analysis going on. And also just making sure that there's a place within the curriculum for the study of opiate abuse. There's talks of a lot of different drugs that will be included in the curriculum. The drugs that you would expect with marijuana, alcohol, cocaine, heroin. And so the push is on to make sure that there's a proper amount of time and resources put towards the dangers of prescription painkillers, for instance.
And how has the parents or even the teachers who in some way may think that this is something that they really shouldn't be tackling, because one, they may not be educated professionally, feel about that whole educational aspect of it.
Well, I think there's mixed feelings. Some people feel that if you put too much information out there, are you giving information to a child that may not yet have been exposed? Is it too early? Are you increasing the likelihood that they may experiment? And others feel that you can't start young enough, that this education has to start at an early age. Children have to be made aware how dangerous these drugs are, and then they have to be made aware of it consistently throughout their education. So you have both sides of that.
One of the, I guess, interesting issues that was identified is parental notification, whether a young, in this case, a young child or a young adult, you know, not quite the age of whether it be 18 or whatever, either overdoses, seeks proper health care, or maybe even something is discovered in school. How does that whole parental notification piece come into play in relationship to perceived rights of the child, I guess?
Right. Another one where there's conflicting, different schools of thought. The legislation that we just passed through the Senate, it does have a parental notification provision in it, that if a child is brought to the emergency room, the child's under age 18, that prior to release from an overdose, the parents will be notified, and the parents and the child will be given educational materials, informational materials as to where they can get treatment, what type of treatment programs are available, what type of resources are available. So that was in the Senate bill that just passed. Hopefully it'll make its way through the House and onto the governor's desk. And I believe that the more education you can give, the better. If I go in and I break an arm, my parents are going to be notified. If I go in with an overdose, I think my parents should be notified. And as a parent of two teenagers, my youngest coming up on his teenage years now, my third one, I'd want to know. And I think if we're going to err on the side of caution, I think it's better to err that way.
I don't doubt that one bit. And what I found really exciting about it was that we kind of identified the age of 18 as the age of, if you're under 18, your parents are going to be notified. So again, that kind of from the educational perspective, if you're a kid out there and you're messing around with drugs and something happens, be prepared, your mom and dad's going to be notified if you end up.
If you skip school and you're 17 years old, your parents get notified.
Truancy.
If you go to the hospital with an overdose, I think parents should be notified.
I think that's really fantastic, and I was happy to see that part of it. The Drug Enforcement Agency recently identified that 12th graders are getting high using the following drugs. 32% of the 12th graders out there identified marijuana, 10% Vicodin, amphetamines at 8%. We had several drugs at 6% being sedatives, tranquilizers, cough medicine, 5% cocaine in any form, as well as cocaine in a powdered form, Oxycontin at 5%, Ritalin, and even the inhalants. What was interesting was that almost 40% of all of these these types of drugs that were being identified are prescription drugs. You know, over-the-counter drugs that have been maybe prescribed to a family member or loved one, or maybe even the individual themselves. What recommendations would the committee have on prescription drug diversion and addiction have to the parents of the schools, parents of our school children out there?
Well, just be aware. Prescription painkillers have a reputation of not being dangerous because